Good afternoon, everyone. I'm Tomiko Brown-Nagin, the Dean of the Radcliffe Institute for Advanced Study at Harvard University. I'm so pleased to welcome you to the second installment in our virtual Radcliffe discussion series, exploring health equity in the time of COVID. As I mentioned at the outset of last week's program, this series reflects three critical elements of the Institute's mission. First, it reflects Radcliffe's commitment, articulated in our strategic plan, Radcliffe Engaged, to examine and address pressing issues facing our society. Second, it reflects our conviction that drawing insights from across academic disciplines and professions allows us to advance public discourse and discern innovative solutions to complex problems. Third, and finally, this series reflects the Institute's commitment to equity and opportunity. As our distinguished guests will discuss, we've seen in recent weeks that COVID-19 disproportionately affects vulnerable and marginalized communities. We have an opportunity and a responsibility to examine the deficiencies that this crisis has revealed and exacerbated, and to help chart a more equitable way forward. Today's program is a part of that important effort. To explore these issues, we're joined this afternoon by two eminent, engaged scholar practitioners. Mary Bassett, an alumna of Radcliffe College, has spent 30 years working to promote health equity and racial justice. She is director of the FXB Center for Health and Human Rights, and is the FXB Professor of the Practice of Health and Human Rights at Harvard's T.H. Chan School of Public Health. Before coming to Harvard, Mary was Commissioner of the New York City Department of Health and Mental Hygiene. Khalil Gibran Muhammad is a Suzanne Young Murray Professor here at the Radcliffe Institute and Professor of History, Race, and Public Policy at Harvard's Kennedy School. Khalil previously served as director of the Schomburg Center for Research in Black Culture, and he is the author of The Condemnation of Blackness, Race, Crime, and the Making of Modern Urban America, among other acclaimed works. Mary and Khalil, I'm so grateful that you're joining us today. Before our program gets underway, let me also take a moment to acknowledge the members of the Radcliffe Institute Leadership Society and all our annual donors. Your generosity keeps Radcliffe programming free and open to the public. Thank you so much. Now I have the distinct pleasure of giving the virtual floor to Khalil Muhammad.
Thank you very much, Dean Brown-Nagin. It's a real pleasure to have this occasion to do this important program. And it's a credit to Radcliffe that it's very much concerned and engaged in this difficult moment when the campus itself is actually empty. I also want to say I'm really great to have a chance to do this with Dr. Mary Bassett, who's not just someone I look up to, but also a colleague and a friend. So I just want to let our listeners know that we'll have a few remarks from Dr. Bassett to get us started, and she's going to show us some things that we'll talk about over the course of the next hour. And then following that, we're going to open the floor, the virtual floor, for questions. I'd like for you all to use the Q&A box, which you can find at the bottom of the Zoom screen. You can put your question there. The shorter and clearer it is, the more likely that we'll have a chance to engage it. And if you're not able to have your question engaged, do note that we'll be taking stock of it. And if we have a chance to engage you in some other way, or Radcliffe wants to follow up, they certainly will do so. So please submit your questions as we go along. And when the floor is open in about a half an hour, we'll get to them. Thanks so much.
All right, I'm unmuted. Thanks very much, Khalil, for that kind introduction. All right, so our topic today is health and inequities in COVID-19. And the first thing to say about that is that health inequities in the United States are very long-standing, and they have tracked particularly along racial lines. The finding that people of African descent had shorter, less healthy lives dates even to the pre-colonial period, even before the United States was a nation. And Evelyn Hammond, a historian of science on the faculty here, has pointed out, and it's true, that there's never been a single year when the life expectancy of Blacks in the United States hasn't been shorter than the life expectancy of whites, and that continues to this day. So we are now in the midst of a once-in-a-century pandemic, but when this novel coronavirus reached our shores, there were already long-standing marked disparities in the chances for a healthy life, and not due to unusual diseases. People often think that the excess mortality among Blacks is due to violence or HIV, but no, it's the leading causes of death, cardiovascular disease and cancer, hitting people at younger ages and taking a higher toll. So next slide, please. When the coronavirus arrived, and these data are just from a week ago, it surprised nobody, I think, that we began to see higher rates of infection in both Blacks and Latinos in the United States. So these are cases, and these are the only data available at national level presented by the CDC, but many jurisdictions, cities, Milwaukee, Chicago, New Orleans, eventually even New York City, where I was once health commissioner, presented data on mortality, showing a big disparity and overrepresentation of both Blacks and Latinos in the number of deaths that were occurring in these cities, with a difference that was 2- to 3-fold, sometimes even 4- to 5-fold higher among Blacks and Latinos than it was among whites. This led to a response by the national figures who are commenting on the coronavirus outbreak, COVID-19 in the United States. Next slide, please. And this is what our Surgeon General said. He invoked alcohol, tobacco, and drugs. And he went on to say, imply that the problem of excess occurrence of COVID infection was related to the fact that people weren't following public health advice, and that the communities of color had to step up in order to do better. In other words, that the problem lay with the community itself. And Tony Fauci, whom is a widely regarded, next slide, please, highly regarded and probably the rightly called America's doctor at the moment, responded by saying that the excess mortality that was seen among Blacks and Latinos was related to the higher rates of many common diseases. This is true, and he pointed out that there was nothing to do about it right now. Now, both of these framings invoke a vision of the longstanding disparities in both mortality and disease that lays the problem within communities themselves, and in particular within the bodies of people of color in the United States, and makes it a problem of lack of fitness and lack of responsibility, and doesn't talk about the problem of exposure. Next slide, please. Now, this slide may be a little complicated for everyone to see, but the rapid emergence, and this happened very fast. It's hard for us all to remember that the first death from COVID-19 was just at the end of February. And now we are in April, and there are 55,000 deaths, actually 56,000 deaths have occurred in the United States. So the rapid emergence of these race-ethnic disparities suggested that we should think about something structural that was driving these. It was too soon to have it modified by behavior among any groups. And this slide shows the number of positive cases in New York City and how they overlap with communities that have a high proportion of service workers, many of whom are now essential workers, have to still go to work even even if they are concerned about their exposure. It also includes people who are rent burdened and the poor, so that you can see that the occurrence of COVID positive cases in New York City is not occurring only according to race, but according to the impact that race has on the labor market, on the housing market, and these are individuals who have to go to work in order to get paid, take public transport that may be crowded, go home to crowded houses, which may be multi-generational. May I have the next slide, please? And so that's the part of the story that isn't being discussed, that the role of essential workers and the way in which people of color are disproportionately, if they have jobs in the workforce that is low paid and precarious, that's part of the story and the risks of exposure that carries. An additional part of the story that's also emerging is a notion that people's behavior needs to be policed. And this is a photograph of a physician who was handcuffed in front of his home because he was doing work with homeless individuals and doing testing for them. Other people have raised the risks that there are, particularly to Black men, of entering stores with their face masks or bandanas on. And so the behavioral explanation is given for why people have more exposure to COVID. And it's also now transitioning to something else that we have a long legacy of in this country. And I look forward to talking more about with Khalil, which is the criminalization of Blackness and the criminalization of poverty, creating an opportunity for something that we should all be very worried about, and that is a policing of the public health response. I hope that we can imagine instead a world in which public health does not act like a police force, and in which essential workers are protected and not blamed for the risks that they face doing the jobs that all of us need. And that's my last slide, I believe. So now we can turn to have a broader conversation about the ways in which this idea that it is people's bodies that make them susceptible and not the structure of the society in which they live, and additionally, the ways in which behavior becomes a basis for over-policing once again.
Yeah, I really appreciate your presentation. It put in very stark relief what the stakes are for how this pandemic both brings the past very clearly into our present, and also affords us an opportunity to learn some things about the past that might make the future different. I'm particularly intrigued because you, as a public health expert and a professional and someone who ran the largest public health system in our country, you have a deep sense of history. You have a sense of the trend lines that have essentially defined people's bodies, particularly those of African descent, as broken bodies, as somehow predisposed to premature death. And we've talked a lot about this together, but I guess for me, I just wanted to talk a little bit more about that history, because I think that many of us right now are struggling with the Trump administration's various policy choices early on, which have certainly contributed to the problem, and the call for more public health expertise. But I suspect you worry also that the public health field itself has some blind spots or some flaws in how it also has prepared itself for this moment.
That's true. And there have been eras of public health. And beginning in the middle of the 20th century, the public health field really sort of hitched its wagon to clinical medicine. And the pathway to health was to have a doctor. And that was very different than 19th century public health, which placed much more of a focus on the conditions of life, the conditions of work, the conditions of your daily life. So housing, sanitation, having a living wage were all much more closely aligned, the way in which cities were designed, to public health in the 19th century than it became in the middle of the 20th century. And it became much more individualized. And the notion of personal responsibility for one's health, and one's health being a consequence of the kind of decisions that you made and how you handled your lifestyle, and including your utilization of health services, really shifted the focus from thinking about what some people now call the social determinants of health. And I think we're beginning to see the pendulum swing back, but for probably 50 years, public health was heavily focused on individual behavior rather than the context in which people can have healthy lives. And yeah. I disagree with that, as you know. Yeah. And I think it also helped lead us to the vulnerabilities that we're seeing unfolding before our very eyes, where the United States, the wealthiest country in the world, the country that spends more money on healthcare than any other country, is now the epicenter of the COVID-19 pandemic.
Yeah, so I wanted to dwell on that broader frame of the wealthiest country in the world, because this has to be a puzzlement to so many people, just as it is to me personally. And I know history pretty well around these issues. It's hard to surprise me with some of this. But in thinking about the way that you frame the 19th century public health notion of structural determinants of health versus the individualized, I've been thinking a lot about how race is the portal through which that transition likely occurred. And that is that you have the massive public health crisis of the end of the Civil War, which immediately puts the burden of the freedmen on states to resolve the longstanding neglect of health in general, but also the immediate concerns about smallpox epidemics that are breaking out that have nothing to do with the people. It's just that they are vulnerable by virtue of the density of population, the lack of sanitary conditions under which they live in that moment. And I'm also thinking about Hoffman. So I've written about a man named Frederick Hoffman, who in many ways is archetypal of the emergence of a kind of a new way of thinking about how to actuarialize life. That is to say that if we can show evidence that the conditions that people live under are roughly approximate, that they're similar, and there were all kinds of tests going on at the time that he was writing for prison conditions being the same, or the army conditions being the same, or even tenement life, that is where poor people lived, all being the same. So if Black people were experiencing more premature death, then it must be something wrong with Black people. And he actually wrote this into actuarial tables in a way that basically said that if we can show proof that people are essentially biologically or culturally inferior, because those two things often are one and the same, the cultural inferiority being a kind of way that Jerome Adams, our current Black Surgeon General, is talking about it, then essentially we should write that risk into how we govern public policies. In other words, we shouldn't waste resources on people who are not likely to be fit in a way that suggests we ought to invest in them. And this not only contributed to the divestment of Black life in the early 20th century that Hoffman played a major role in, but it also contributed directly to the policing of Black life. And so I would say, if I'm wrong, Mary, that public health and criminal justice system on the issue of anti-Blackness converged fairly early on in the United States of America.
Well, one thing I know is that I was looking, because last year we were all marking 400 years since the first enslaved Africans, or first unfree Africans, came to these shores. And many of the people who I would consider the progressives in public health wrote about it from an immigrant perspective. They left race out of it altogether. And this is a really kind of astounding blind spot, because the sickest population in the United States were, in fact, people of African descent. But many progressive public health people just didn't talk about it. So I think that these two are likely to be to be interconnected, as you're hypothesizing. I mean, as you know, Frederick Hoffman predicted that Black people in the United States would simply become extinct. And he attributed the high mortality to some kind of inherent fitness. And that is something that has become so normalized. There's a reason that none of us are shocked that COVID is taking a threefold higher toll in some cities on Blacks than it is on whites. We're used to this.
Yeah.
At the same time, we have to accept the biology that that we are in fact all human, and that there's no biological basis for this. So I think public health has in many ways failed to raise its voice about the impact of white supremacy on its practice.
Yeah. Well, I think I've been listening also to Dr. Kamara Phyllis-Jones, who is also a Radcliffe Fellow this year. She's a former president of the American Public Health Association and a Morehouse affiliated faculty member. And she's been very clear about how much the social determinants of health research has both been working to document the structural causes of Black premature death for over 20 years, and has reached a conclusion that is quite striking in its full-throatedness, that ultimately this is not a data problem in the sense that we think tracking the premature death in the midst of the COVID crisis is the thing that's going to save us. Because that's what's so astounding about your bringing up Jerome Adams and Dr. Fauci. Because that social determinants of health doesn't enter into the actual policy and practice work that is happening right now. It's as if it doesn't exist, but of course it does exist. So what's your take on the
this is
relationship?
Where we disagree. Well, I'm a numbers person, and I think that in the absence of these data, we're not able to shine a light on the problem. And I think that we do know that the data change when the policies change, and that individual behavior change will never be enough to do this. But you're absolutely right. This is an ideological problem. It's not simply an ignorance problem. There's a reason that Dr. Fauci goes immediately to talking about the fact that there's a higher rate of diabetes, obesity, which is true. And that explains worse outcomes if you get infected with COVID. But it doesn't explain the higher infection rates, which is related to where people live, how they get to where they work, whether they can work from home or not, whether they can afford to stay home when they're sick, whether they have health coverage so that they can afford to seek medical care. All of these structural things that you correctly put under the social determinants of health are outside of the vision, the line of vision for many people who are working in health. There's no natural boundary to the sorts of things that can affect our health. And I think people in health should not be afraid of talking about them. But I do think the numbers matter. If we don't have them, then how can we you and I are sitting here talking because these have hit the headlines.
Let me correct that and just say that they are necessary but insufficient. That's really what I was trying to get to. Because here I'm going to throw a disparity data point. It's not so much limited to a singular number, but it is very revealing. So we're getting report after report of more and more evidence of what happened to Dr. Armand Henderson. That couldn't be a more revealing intersection of public health and policing. Here is a physician doing outreach to support homeless people, wearing a mask, trying to make sure that they have PPE as best that he can distribute it. And he gets essentially nearly arrested and taken into custody for something he wasn't doing. And of course, his explanation was insufficient. And that's what you showed. But we know that his experience is a problem. And the New York Times just reported on it yesterday. So take that alongside of the other side of the equation, which is that, and we're probably going to hear from some of our audience members very soon around this. The New York Times reported on Sunday on the front page that the University Hospital of Brooklyn, part of the ground zero problem of the pandemic, hitting the hardest communities in Brooklyn, a massive public health facility that has been subject to decades of disinvestment. It's literally falling apart, and yet it has the greatest need for public health workers, PPE, medical equipment. And in Manhattan, at Mount Sinai, serving one of the wealthiest populations in the world, they hire private jets to pick up N95 respirators.
They borrowed them. They borrowed them from Warren Buffett.
Yeah, like so.
Yeah.
So we're having more policing of the poorest communities facing the greatest disadvantage, being asked to give the greatest sacrifice as essential workers. When they show up in the hospital, they go to the worst possible hospitals, and somehow. This is my problem with the data problem. Like, yes, we can have this conversation about it, but too many of us invest in having that conversation around it and not supporting the organizing, the movement work, the political work, the accountability work that is required to make sure that we don't have surgeon generals like Jerome Adams in the future, no matter what his demographic background is, and that we elect the kinds of political leaders that are going to make sure that public health serves the greatest good, that is all of us, that every life is precious.
I think we've seen in the last 40, 50 years a huge disinvestment in the public sector, and a growing sense that anything that government does is not worth spending money on, growing mistrust of government, and along with that. But there's really no way to have an effective response to a global pandemic without government. And in my view, there's really no way to have an effective clinical care service without having it, become a national project. But instead, we have small community hospitals that are valiantly trying to serve poor neighborhoods. The public sector hospitals are taking the brunt of the COVID outbreak, where there are public hospitals. Many of them have closed, leaving these small private hospitals to try and struggle on. And you're absolutely right. This is wrong. And that what will change it is a movement. But I hope that it will include historians, public health workers, all of us, because I think that being able to put numbers on problems helps people to understand them better. It doesn't create change.
Yeah.
And these data that we're seeing are ones which can be changed. And some of the things are actions that we could take right now. Essential workers shouldn't have to, fight to have masks, shouldn't have to fight to have paid sick leave, shouldn't have to fight to have hazard pay, which remains hugely controversial. Even though people are being asked to work very low-wage jobs and potentially be exposed to a life-threatening infection. These are things that could be tackled with policy right now. It's true, we can't do anything about somebody's obesity next week, but we can do something about the fact that they can't protect themselves from COVID when they go to work.
Right. Well, even something as simple as obesity next week is the difference between a social provision system or social welfare system, like in many other European democracies in the world, that means that the poorest people aren't living in food deserts and subject to food insecurity, where no matter what your preferences may be, you're subject to processed food because that's what's available in your community. So we have options.
It's a big problem, but we have options.
We have options. Well, we are going to move to our Q&A, and we've got some great questions here. And this first one is an interesting one because it puts the onus on us to help think about what people ought to be doing right now. This person is applying for a community action grant up to $10,000 and wants to know what would be an effective immediate use during the COVID-19 moment for community-based outreach and work. So if we had $10,000 as a community person, how would we best spend it?
How would we best spend it? Well, I don't know where they are, but I hope that they're in a place where there are more services available than you can buy with $10,000. So I would think that getting people to claim their benefits is often an important role of community organizations. People often don't know what's available to them, and a community organization can get out there and make sure that people are aware and that they get to the front of the line. I think that there are wildcat strikes going on all the time. There was one in Staten Island at an Amazon warehouse recently. Warehouse workers work under assembly line conditions. They have not started out with having adequate personal protective equipment. They may have it now, but what about their sick leave? So I think getting information, supporting workers would be a good thing to do with that $10,000 too.
I like that. That's a pretty radical response. I mean, you're basically saying that education and outreach and organizing and perhaps even supporting through the basic needs of people who are striking, like food and that kind of immediate support.
That was what
has much greater stretch for $10,000 than simply a charitable effort to try to feed people or provide some very basic care. Our next question has to do with the Native peoples in the United States, indigenous populations, and their crisis of health care and inequality. And I haven't seen a lot of reporting on the precise disparities of cases coming from within Native communities around the United States. Obviously, to some degree, they are more rural and less dense, but sit on top of centuries of similar neglect as many African-American communities.
Genocide. I mean, they were the target of a genocidal campaign, and the Navajo Nation is having a terrible COVID outbreak. So people may be dispersed, but they may still live in dense housing, in crowded housing. And for the Navajo Nation, many households don't even have running water. So when you think about the kind of public health advice that's being given, wash your hands, the simplest thing, many households don't have the capacity to do that. The Indian Health Service has been under-resourced for ages. So it's important to include, and I should have done that, the role of Native American Indians as also having had huge health disparities. Rising mortality, actually, over the past several decades.
Yeah, and keeping with that theme, I mean, this is a question I have a thought. I'm going to let you take a stab at it first, but I've been thinking about this because Brandon asked us, for example, that if we know that African Americans get hit the worst when there's economic recessions, when there are natural disasters, as what occurred in Hurricane Katrina, on top of a man-made disaster with the levees failing, and now with the COVID pandemic, one might think that our public health sector and other elected officials would actually take those trends and focus their energy and effort in the communities that they would assume would be most likely to bear the brunt. And so in this case, both the Native communities and this country. So within the public health sector, I mean, how either through experience or through your own understanding, how is it that they keep not thinking about the most vulnerable communities as places to start testing regimes and or distribution of PPE, et cetera, et cetera?
I think it's this notion that certain communities just have cultural barriers to being well behaved, and following medical advice is very strong. I think that our Surgeon General was, trying to model, speaking in a language that, quote, his people would understand. And
he said that actually. Yeah.
Oh, did he? Okay.
Yeah.
So this notion of that people, are doing what they're doing because they're either ignorant or defiant or some blend of these, rather than they simply don't have the capacity to follow public health advice. That notion that the problem lies with communities is very strong. So what you'll typically hear is, let's have an education campaign. That doesn't fix being a precarious low-wage worker who can't afford to go to the doctor, take a day off of work, comes home to a multi-generational household where grandmother may get sick. Those aren't lifestyle choices.
Right. Yeah.
It's
yeah. And unless I'm missing something, I've still not seen any significant reporting on the shifting of resources precisely to these communities. For example, New Jersey has announced that it has rolled out one of the first rapid tests for COVID-19 with a quick swab of the nose and results within 15 minutes, if I'm not mistaken, that's developed by Rutgers. But you still have to literally live in Middlesex County to qualify for that.
Right. And these drive-in centers, you have to have a car. And
yeah, no, it's pretty unbelievable.
Yeah.
So
Yeah,
our next
true.
question gets at a term we haven't used in this conversation, and we've covered some of this. But Bradley Dennis is asking about the relationship, sort of the longer relationship of slavery and the interaction of environment and genes. So how do epigenetics interact with social determinants to contribute to the quote unquote comorbidity problem?
Right. Well, you know, we are biological beings and our genes matter. But I think that the evidence is sufficiently convincing that we should focus on the environment first. Focus on how people are living before we go searching for epigenetic things.
Yeah. That's kind of like saying, why don't we focus on the 99% that makes us all the same, and as a set of policy choices?
That's right.
As compared to searching for the mystery of that 1% that animates so much, or 0.1%, whatever. In some ways, you know, for those folks, it never would matter how small it is, as long as there was some uncertainty, people would search for it.
There was some, I don't know whether they're still with us, but 2 faculty members at Harvard said that if nobody was left on the earth to repopulate the earth except the Maasai, a group in East Africa, we would still have 98% of human diversity, although of course we'd all be darker skinned.
Yeah. So this next question from Susan Stout asks about most achievable first steps. So, you know, being very practical, thinking about putting on your commissioner hat, what are the first steps towards changing what's happening on the ground in this particular moment, things that people haven't really thought about?
Well, I think that the protection of essential workers is pretty straightforward. Everybody seems to view health workers as people who deserve protection, but so do the people who are working in supermarkets at the checkout counter, delivering, running transport, delivering goods, working in these jobs where they're considered essential. They need the same kinds of protections, and they need the same options that are being generated for health workers, like the option to have an alternative place to stay. I think what I've found most wrenching are these stories that people tell about being terrified of going home and bringing COVID-19 with them. And the solution to that lies in our empty halls of residence for students and the empty hotels. Those are things that really could and are in some places being addressed directly. And of course, people shouldn't have to buy masks, should have their employers thin out the workplace so that the 6-foot rule has more meaning. Our prisons and jails should be reduced in size, with anybody released who is not a threat to public safety. These are all things that could be happening right now, rather than hammering on this idea that people are already so sick we can't do anything for them, but try and look after them when they come down with COVID.
Yeah, it's interesting because, I mean, just to echo your point, we have an anonymous person submitted a question to talk a little bit about the incarcerated experience for those who are inside. And in some ways, it encapsulates a kind of perfect expression of the relationship of our environmental conditions and those most vulnerable. So people incarcerated literally are trapped in a environment that breeds not just the easy transmission of a contagious virus, but also the lack of sanitary options and conditions to stem or mitigate that exposure. And yet, I don't know about you, but I've read online, in social media and comment boxes, that in response to political and organized pressure to release people, to not put people in, to have compassionate geriatric release, to do it once and for all, to stop dithering about it. A lot of people have said, those people should rot in there. They shouldn't have done what they did in the first place.
Really?
So it's a quite, I mean, these are, of course, a subset of the population, but nevertheless, it articulates the way that when you embody something that has been defined as morally abhorrent, as dangerous in and of itself, that you can't in fact be vulnerable, that whatever you did to land in prison
you deserve to die for it.
You deserve to die from COVID, as if that was the punishment.
Right. I mean, maybe it would help to point out that the people who work in the prisons are also becoming infected.
Yeah.
Corrections officers are becoming infected, and that the health facilities that serve these communities are, now having to face an added burden of very sick people. People who are incarcerated have the right to health care. They have it not just because it's a moral right, but it's actually litigated and agreed to by the Supreme Court that people who are incarcerated have not forfeited a right to health care. So thinking about the way in which COVID affects us all, and the fact that it spreads in the air, and as long as it's present in some parts of our society, it's a risk to all of us. I hope that will become a reason to see that, even if it's self-interested, to see that it won't do to have these ongoing transmission in certain sectors. It can never be contained.
Yeah. I mean, I don't want to overstate any of the kind of white supremacist narratives that most certainly circulate on 4chan and other places, or the fact that the Trump administration has Stephen Miller, who's been designing immigration policy. I mean, we can't separate those things out as if they're not real, but we also can't overstate the goodwill of many people to support some very important justice system changes that are bearing significant fruit in the moment of the COVID crisis.
I hope so. Are they? Yeah. I mean, I think many more people could be released, certainly from jail, where most people are pre-trial. Anyone who's not a threat to public safety, I just can't see a justification for keeping them detained.
So that's why the policing practices are are sort of short-sighted. One wonders what's the conversation inside of Mission Control, inside of the de Blasio administration, or any number of other city administrations, when on one hand is trying to release people from jail or to not engage in the usual court practices, and on the other hand, they're sending police out to police social distancing. We have another question from Sonia Marion. She thanks for the presentation, and she says that systemic racism is being shown to be brutal and tragic right now in the midst of the pandemic, but this has not been unknown for most of the healthcare community. Would it be your recommendation to communicate to our representatives and senators and employ them, these elected officials, as a vehicle to fight for recognition and commensurate support for Black, Brown, and poor communities? That is, what is the role of the public health sector itself in advocating for political change?
Well, I think that having conversations like this is part of it. And for people who are watching, I hope that they'll continue to have these kinds of conversations, but certainly weighing in on our elected representatives, talking with them about the fact that 13.5 million more people will lack health insurance come June because of job loss, if not more. That it's so, these are things that are direct policy arguments to slow the rates of arrest, the rates of pursuing charges, and to reduce the population of people who are incarcerated. These are very specific actions that would help protect us all.
Yeah. Someone reminds us in a question to think through and remember how so much of the anti-Asian sentiment, some of which we heard from the president himself, as well as within a broader community of Americans about the Chinese virus, and of course the evidence of the rising uptick of anti-Asian violence and racial epithets itself, is also part of a longer American story. I mean, some of the first public health campaigns were directed exactly against Chinese immigrants in the West Coast as sort of vectors of tuberculosis and other forms of contagious disease.
That's right. That's right. That certainly happened in San Francisco during a concern about plague, and of course the people of Chinese descent were the subject of the first targeted immigration regulations that named ancestry or national origin, the Chinese Exclusion Act in the 1880s. So the willingness to scapegoat increases during periods like this. And I think that's why we're talking about this kind of transition to policing rather than helping populations. And we've seen it happen before, directed at the Asian population, and it's happening now in terms of individual acts of discriminatory behavior. I haven't heard of anything of course we have the president, and the language he uses, but I haven't heard of any legal actions taken against Asians as a group.
Yeah, and I suspect that in California in particular, there's likely more local reporting on the particular disparities that are impacting the broader Pan-Asian community, which of course runs the gamut from Asian Island, Pacific Islander, to East Asian communities, which tend to be wealthier and not be as commonly or disproportionately represented in essential jobs.
Yeah.
Someone's asking here about disparities in funding and support to hospitals and clinics in the inner cities for underserved population. We talked a little bit about this, but is there something more to be said about the existing infrastructure of community hospitals, public sector hospitals?
Sure.
And that is a kind of predictable part of the problem of what it means when pandemics fall or happen in a population.
Well, certainly in New York City, which is still the city that I know best, private hospitals are often paired with public hospitals geographically. They exist side by side. And there's no doubt that non-paying and publicly insured patients are being pushed over to the public hospital sector, reserving the high, the well-insured and high-cost procedures to the private hospitals. So private hospitals have a very healthy bottom line, as we started out talking about, and the public hospital system's always awash in red ink. This reflects the fact that they're delivering care to people who need it, but who don't have the resources to pay for it. And, this has been going on for decades. The public insurance reimbursement is just not enough to keep these hospitals afloat. And they add that to that, people who don't have insurance at all. So this is a structural problem in our healthcare system that has resulted in longstanding two tiers of care. And it's not the way that we should be delivering healthcare.
Yeah. I mean, just to put a bow on what you just said, of course, there's the infrastructure itself, and we've already talked about the University Hospital in Brooklyn, but we could repeat that story across many parts of our society. But of course, Obamacare or the Affordable Care Act still left millions of Americans without health care, which of course has animated the 2020 Democratic presidential race. So one can only speculate. Neither one of us can look into a crystal ball here, but one can only speculate how the COVID pandemic might in fact change the conversation about Medicare for all or a single payer system or some form of universal health care that has not yet been achieved.
That's right. I mean, there are 28 million people who didn't have insurance after the Affordable Care Act, and the numbers of people who've lost their jobs and thereby their health insurance mean millions more will be added to that number. So I can't think of a more dramatic example of how crazy it is to insist that people only get health insurance when they're employed, when they're under the age of 65. So I hope, we need to have a lot of things different than they are. And this is a rich country. It's possible to do this and still have very rich people. But right now we have a system that exposed us. And, I I guess we should see what other questions we have. But this is why we're having this terrible COVID outbreak, is because we have too many people who had low wage, precarious jobs, no paid leave, went to work sick, traveled on crowded transport. All of these made very predictable the kind of outbreak that we're witnessing unfolding, and the demographics of that outbreak.
Yeah, to that point, the MTA of New York, the Metropolitan Transit Authority, has more COVID positive employees than any other city agency, exactly to your point about keeping the city going and who has to do that work.
And nearly 20% of the NYPD are out for various reasons. Either they're being quarantined, they've been quarantined, or they're sick. So they're frontline, they're being exposed.
So we have a question about surveillance, contact tracing. Maybe peel back the hood on this a little bit, because on one hand, we know that that the Chinese are using contact tracing as part of their reopening strategy. We hear a lot about it as a public health strategy for managing all kinds of epidemics. But of course, it does raise a question about surveillance and privacy. And so talk us through exactly what we should anticipate that would resolve or not raise these questions around surveillance and the misuse of data with contact tracing.
Contact tracing is a very long-standing public health tradition, and it's been done for managing TB and bringing the numbers of tuberculosis cases way down. Sexually transmitted infections are also things for which contact tracing, in fact, any number of communicable diseases. And health departments have a tradition of doing this in ways that are respectful, non-punitive, and protect people's privacy. Health departments know how to do this. It's just that the resources for contact tracing have been really stripped year after year. In order to do contact tracing for COVID, we will have to have literally an army of contact tracers. And I think that the ideal thing would be for them to do all sorts of things, the kinds of, identify other needs that people have, and really serve as more general outreach workers in addition to trying to track down. I think that it's possible to do this and protect people's privacy. There's a long tradition of doing this, but it shouldn't crosswalk with the police. It just shouldn't. There needs to be a civilian public health activity. And the idea here is the way an epidemic spreads is that there's a chain of transmission. And you break that chain by finding the people who've been exposed, asking them to sequester themselves for 14 days, the incubation period, and then they won't give it to anybody else. The reason we're seeing this explosive spread is because everybody who gets infected gives it to more than one person. So the outbreak continues to explode. And we need to get it down below 1. And that's what contact tracing can achieve. But the numbers of people that would be required for this is quite astounding. But it's doable.
We are. We're going to enter into our last question or two. And I just want to say that people have written some amazing questions. There are too many in the time that we have, which just shows how interested folks are. And before I forget, Radcliffe Institute is doing a program on Native American communities on May 12th. And so to pick up that thread, you'll have another opportunity on May 12th to tune in. So we have a question here about the CDC, and maybe just to hear your thoughts about, so what's the postmortem, at least, the early Monday morning quarterbacking on what the CDC got right and what the CDC got wrong, and how might they carry us through the rest of the way in the most effective way?
Well, the CDC is our federal public health agency, and what they got wrong was the testing. And I can't explain it. But they definitely got that wrong, and I think that's put them on their back foot, up to now. Additionally, this whole response is being run politically, and we're not seeing the type of public health leadership that one would expect when we're confronting a public health threat. So there are many wonderful people who work at the CDC. Who are still there, even as the political leadership changes. And I would love to see them standing and briefing us, but we're not getting that kind of input. The last person who did that was sent to a corner.
Oh, wow.
The head of the immunization. I mean, she didn't lose her job, but the head of the immunization program. So I think it's really unfortunate when what's essentially a technical agency gets highly politicized in this fashion. But they remain a very fine technical agency. They got the testing wrong.
Yeah.
They sent out tests that didn't work.
That's right. Yeah.
And they were available from the World Health Organization, but we wanted our own. Now, they've done all right at this in the past. I don't know what went wrong. I really don't.
All right. Well, I'm
the last question. Sorry if I went on too long about it.
No.
But I'm a big supporter of the CDC, and particularly the state and local health departments. And we just haven't seen enough of their presence in the response to this outbreak.
Yeah. So I've scrolled through just about every question, trying to at least lay eyes on them and see if there are general themes. And a lot of questions, just to wrap things up, are really interested in wrestling again with the structural racism origins and context for the disparities that we see playing out. And of the many thoughtful comments about that, and wanting to drill down deeper, one question that I thought was helpful. You showed maps, color-coded maps during your presentation. And the question really is about how to mobilize data visualization to put it in the hands of organizers and movement people and others. People have been asking about if I had $100,000, not $10,000. And my guess is that you'd say the biggest bang that you're going to get for your buck in the midst of this pandemic is spending that money to help that organization and movement work, because this won't be the last pandemic we're going to see. And so if we don't plan for the long term, we're going to keep fighting with our backs against the wall. Does that sound about right?
That sounds right. Well spoken. I tell you, some of the best thinking is now coming from historians, much as I have loved working in public health. But I would say, yes, that's a grounded response.
Yeah. Well, thank you so much, Dr. Mary Bassett. This was a lot of fun to share this moment with you, and also a very serious conversation about a lot of important work that needs to be done so that as we started out the conversation, we can have a better future than we've had a present in the past.
Yes. That's what I think we all hope will come out of this. There's so many things that we could and should change. This is not about defective people. It's about social problems, ones that we can fix. Thank you.